they all do exactly the same thing, so it's kind of hard to separate the drugs out a little bit sometimes. So it's going to be a beast when it comes to like memorizing and actually doing this. And then when you actually become a clinician, it becomes a little bit easier when you're regularly using these drugs, right? The same thing, I made sure to try and use your guys' textbook as best I could for most of this stuff. I did have to reach out and use a little bit of like Stahl, psychopharmacology, UpToDate, a couple other resources just to kind of flesh out all the material and make sure it's good. But predominantly, I made sure to try and use y'all's textbook. So that's our learning objectives. That's our goal by the end of this, is that y'all will be able to do all of that. All right, so antidepressants. Again, we're not going to dive into each one of these conditions right now. That's what we're going to do during this psychiatry block. But when we're talking about the antidepressants as a drug class, as a big overall umbrella, this is just a few, when you're talking about just psychiatry, of the things that we use these drug classes for, right? Have you guys had a pain management lecture yet? Next person? Okay. So you'll also kind of see these drugs pop up over and over again. You'll see a lot of like the TCAs are used in pain management, migraine prophylaxis. I think you guys on your last test had Parkinson's, right? So you'll see those MAOI inhibitors that we're going to talk about. They showed up and predominantly used in Parkinson's disorder and that sort of treatment. So you'll see these things pop up multiple times in different classes that we're talking about, okay? So we're going to try and just focus on the psychiatric perspective here. So first up, we're going to talk about your tricyclic antidepressants. So tricyclic antidepressants came out in about the 1950s. They were one of the first drug classes. Also along with the MAOIs. MAOIs came out about the same time, the 1950s. And for a while, that's all that we had, right? Then probably around the 70s, 80s, we start to get the first SSRIs that come on the market. That's going to be things like your Prozac, which was the first one to come onto the market. And then later on, kind of the 90s, 2000s, we start to hit the SNRIs, really start to come onto the market, and that kind of flushes out the entire drug class. And then unfortunately, at the very end, we have this random catch-all called the atypical antidepressants. These are things that we use to treat mental health disorders, but they don't fall neatly into one of these other classes, right? And we'll kind of talk about those at the end. They're the oddballs. So first up, kind of those neurotransmitters. Again, I'm just going to focus on the big three. Please keep in mind there's a lot of other ones that go on in the background, but broad view, these are the big ones we're talking about, right? Dopamine, norepinephrine, and serotonin. When we're using these meds, we're really trying to cause an effect in one of these three. And the general theory is that, hey, you have a mental health condition because you don't have enough of one of these three. So if we increase that, it will fix your depression, right? That's a very simplified view of that hypothesis. For right now, I think that's probably good enough. So the big one that you guys are talking about for this hypothesis from a pharmacology perspective is the biogenic amine. So again, essentially, you have all these chemicals, these neurotransmitters. We have a decrease in them, which is now causing your depression in the various parts of your brain, right? So your rapha nuclei, you have these fibers that are spinning along the tracks, you have your limbic system, you have your prefrontal cortex. Essentially, your brain doesn't have enough, which is leading to a mood disorder. So if I increase it by causing a blockade somewhere, there'll be more that's available, right? But just keep in mind, if this was the primary issue, we would have fixed depression back in the 80s when we actually had these meds, right? Which is not actually the case. You're having a huge spike in mental health disorders within the broader community, and it's being diagnosed more and more frequently. So this is one part of what causes a mental health disorder, but this is not the fix, right? There's a lot of other things that go into that. So whenever, and this is just kind of where we'll leave it at for this portion, anytime you're approaching a patient with a psychiatric disorder, you always want to use a biopsychosocial framework. So biology, that's where we talk about maybe they're having a resistance to that serotonin. The serotonin is actually low. Then you have that psychologic, so kind of like what's going on with their mindset, how are they interacting, how are they sleeping, how are they exercising. And that social framework, that is like, okay, what is their environment that they are in? Are they in an abusive relationship? Are they on low socioeconomic status? All of that comes together when we're looking at a mental health disorder, and all of that interplays with that, right? And that's a story for another time. That's something we'll talk about in your psychiatry course. But for right now, we'll kind of leave it at that portion, right? So I know that was, again, trying to keep it very simple, broad overview, but it helps if you guys have the basic pathogenesis of these meds, and that's why we use them. Before we kind of start jumping into the meds themselves, any questions about that category? Cool. Going once, going twice, all right. So, black box warning. Anytime you have a black box warning, it's really good to kind of know that. And this one is present for all medications that fall under that antidepressant umbrella. They all have the exact same black box warning, right? Which is essentially, these meds, the moment we give them, there's going to be an increased risk for suicidal thought and suicide attempts within the population, right? This black box warning is rather contentious because the data is very gray, it's very nebulous, depends on who is conducting the research, what they were looking at. But it doesn't matter. The FDA came out and said, hey, this has to be on all your black boxes. So anytime that I'm talking with a patient and I'm initiating one of these meds, I don't care if it's the first time I've done it or the 100th time, I'm always going to tell them, like, hey, just so you are aware, anytime we initiate this med, there's increased risk for suicidal thoughts, suicidal activation, suicide attempts within the population, right? When we have this, we generally, the biggest risk group is our teenagers to about the age of 25, right? That's who we see like the biggest increase in attempts is in that population. Once you kind of hit over the age of 25, it starts to taper off, but I still, even my 30, 40, 50-year-olds, I still give them the exact same warning, right? Because again, this is one of those things you don't want to miss when you're talking with your patient. In reality, the entire time I've been practicing, I've actually only ever seen one case of this where we could directly link it back to the SSRI. I've only seen one case of it. And what had happened, there was a young kid, he was an AIT soldier, he was having some stress, some anxiety about being in the military. One of his primary cares had initiated him on, I think it was Prozac. And within about a week, he had started to become suicidal, was admitted to the inpatient floor, and the only thing we could really identify was the med change that contributed to his suicidality, right? So we were able to chalk it up to, hey, med probably caused it, so we switched him from one med to another one, symptoms resolved, right? When I'm talking in general, and kind of this is where the confusion comes out of, patients who get started on antidepressants, right, they generally have low energy, low motivation, they don't want to go and do anything. So they might have suicidal thoughts, but they just don't have the energy to act on it, right? Then I give them an antidepressant, it starts working, they actually start having energy again, they have motivation again, and now all of a sudden they can act on those thoughts that they're having. That's generally what we see with it. The suicide was always there in the background, the medication started working, and then they had the energy to act on it, right? So that black box is going to be for all of the antidepressants. It's one of those things you'll probably have a question about that. Just depends what that question takes. So first up, tricyclic antidepressants, right? This was the original, and the best way to kind of think about TCAs, it's like taking a wrecking ball to depression, right? They work, but they're not very selective. You're hitting all sorts of neurotransmitters when you do this. You're hitting all the receptors. So yes, we're blockading with that serotonin and that norepinephrine. But if you guys remember from the antipsychotic lecture, we're also going to be hitting our anticholinergic, we're hitting our histamine, we're hitting our alpha-adrenergic, so we're causing all those other problems, weight gain, sedation, hypotension, arrhythmias. We cause the same problems with these TCAs, right? Right down here, this is one I definitely want to make sure I highlighted out. So again, anytime you have a unique condition, this is unique to the TCAs, and I'll leave it at that. This is unique to the TCAs that cause this YQRS complex tachycardia. This is different from torsades, right? So torsades, you get that ventricular widening and the narrowing. Widening and the narrowing. This one is just wide all the time, and you have to treat it differently, right? So instead of giving them magnesium, we're going to give them sodium bicarb, and it actually displaces that TCA from the sodium ion channel and knocks it off, right? So it gets them out of that arrhythmia. So this is one of the things I definitely know. Anytime you have a known adverse effect and there's a known treatment for it, it's one of those things you want to know, right? Don't get it mixed up with like epinephrine for an arrhythmia, with magnesium sulfate for the torsades or anything like that. It's unique and it's different, okay? So this is all of our drugs that fall under the TCA. There's a bunch of them, right? They all kind of generally do the same thing. So again, as we're going through them, try and focus on what makes them unique. The biggest one that you're going to see, amitriptyline, that is used quite a bit. Believe it or not, it's one of the drugs that we use in migraine prophylaxis. So you'll see that quite a bit in primary care. That's one of its primary uses, right? Next, clomipramine. Clomipramine is unique because it can be used to treat obsessive compulsive disorder, right? That's one of its known uses for that. So that's another one you'll see kind of pop up pretty continuously. Your next one, doxapen. Doxapen, it's kind of 50-50. It pops up pretty frequently. In practice, you'll actually use doxapen quite a bit. But we don't use it for depression. We actually use it for sleep. If I give low-dose doxapen, it hits that histamine 1, that histamine release, makes people super drowsy and sleepy. And you can actually use it as a sleep aid, and it's about as effective as all our other sleep aids. Like, it sort of works, right? Those are your big three that you probably absolutely need to know. The other ones, if there's something unique about them, try and know it, but they kind of start to blend in, right? So amitriptyline, like we already talked about, so neuropathic pain and migraine prophylaxis, where we tend to see it. Those anticholinergic effects, that's pretty common across all of the TCAs, but I kind of spelled them out for you. That way you don't have to do it for every single slide. There is a generic formulation. I've never used this just because I don't really like to use TCAs in psychotic patients. But there is a formulation that you can use like severe agitation, anxiety, and kind of starts to hit that schizophrenia spectrum, okay? So yeah, that's something that's kind of unique about it. Amoxicillin, this one, what makes this drug relatively unique is because it hits a lot on that D2 receptor. So if you guys remember from your antipsychotic lecture, anytime I'm hitting my D2, I'm really kind of starting to cause a really bad dopamine blockade. So it's one of those ones that can actually cause our EPS symptoms, right? So if you guys remember those, that tardive dyskinesia, that dystonia, akathisia, like this is a drug that can cause those, okay? So next up, clomipramine, like I said, we really only use it for OCD. That is like the one thing that is known for. Desipramine, not really used that much. It tends to have a lower affinity for H1. So if you have to use a TCA and you're worried about that drowsiness, this is one of the ones you can use. But otherwise, it kind of sits there in the background. It's available, right? Next up, you have doxapen, like I talked about. So doxapen, that's the one we use a lot as a sleep aid. So again, it's very potent for that H1 receptor. Tends to make people very, very drowsy. And when you're talking about these side effects, that orthostatic hypotension, that sedation, that dizziness, if we give it at night, it tends to lessen those symptoms. So this is a med we give at night as well, okay? And ifipamine, so this one is unique in that it's for childhood enuresis. So again, not really in the psychiatric world that we use it too much. But if you're doing like CAP, so child adolescent psychiatry, if you're with urology and you have a kid who keeps wetting the bed, it's a med that can be used. It's not first line. Your first line is actually desmopressin, if I remember correctly. But if that one fails, this is one of the ones that they'll commonly use, okay? So and the last one, kind of nortriptyline. So again, depression, neuropathic pain, nothing really kind of makes it stand out. I guess what's unique about this one is it's kind of similar to that amitriptyline. It's one of those, it's not a true racemic mixture, but it kind of has the same chemical formulation, but not too much is unique about the nortriptyline, okay? So again, your biggest ones, amitriptyline, doxapen, and imipramine, those are like the big three high yield ones that you need to know. They're also used pretty commonly in practice, and then your other ones, if there's something unique about it, definitely try and know like that unique enuresis one, okay? Any questions about the TCAs. Again, biggest thing I'll tell you guys from a clinical perspective as primary care, if you're treating a patient who has like major depressive disorder, anxiety, or something like that, this should not be your go-to. You really want to use this SSRIs or SNRIs. This is usually reserved for patients who are treatment resistant, they fail multiple medications. That's really where we start to jump to this category because of that overdose risk. So again, anytime dealing with a psychiatric patient, they're suicidal, they're going to, a lot of times they reach for a medication bottle that they've been prescribed to try and do that overdose. TCAs cause that cardiac arrhythmia, so they cause a lot of problems with overdoses. The safety profile, we try not to use them, right? Pain management, they like to use them. Migraine prophylaxis, that's really where they kind of have their use. Psychiatrically, treatment resistant, that's where we're kind of starting to see them. So any questions about TCAs? Cool, moving on. All right, so selective serotonin reuptake inhibitors. This is the big category. This is the ones that we use most commonly. They have a pretty good safety profile. There are some side effects that are pretty well known with the SSRIs, but we like them. They're our go-to, right? They work. We know they work. We have a lot of data behind them. The big thing when you're talking about the mechanism of action for serotonin is it only targets the serotonin receptor, right? It's not going to hit any of the others. So essentially, we cause a blockade of the receptor. Now you get a big increase in the amount of serotonin that's available to the body, right? But it takes time to create new neurotransmitters and new receptors that can actually utilize all that extra serotonin. So that's why, because again, I cause a blockade, I immediately get an increase, but it takes time for the body to use that. That's why any of these meds, they have about a 2 to 4 to 6 week delay before we actually see any sort of improvement, because your body has to create new receptors for all that extra serotonin. That's kind of like the general idea behind why they work and why there's such a delay when you're using these meds. They're not instant. Okay? Most common side effects, you can kind of see that nervousness, dizziness, insomnia. This is kind of, there's a big old asterisk with this. So what I'll say is, again, anytime you're dealing with psychiatry, a patient can have any side effect at any point in time, right? That's what I kind of work under most commonly. Most commonly, our SSRIs tend to be activating, so we give it in the morning because we want our patient to sleep. There's one big and notable exception, and there's a couple smaller ones. And we'll talk about the big notable one that's absolutely known to cause sedation, right? That's a big one right there, is that kind of insomnia. Make sure you give it in the morning when you're first starting out. Sexual dysfunction. This is a big one that everybody complains about. It's one of the reasons that people stop taking our meds is we mess with their sex life, right? This is not just unique to men. So men, don't just think, oh, erectile dysfunction, it only happens to us. Women, you can actually cause a lot of the same side effects in the female population as well, right? So you imagine you're dealing with a couple, one of them has depression, their relationship's already on the rocks, and maybe the only thing that's keeping them together is that physical life, you're still touching, you're loving, you're getting that oxytocin release, and all of a sudden, you cause issues with their sex life, you just made their marriage significantly worse, right? So it's something that you need to counsel and talk with your patients about. That sexual dysfunction is going to take kind of 3 flavors, right? So the first one is they just lose their libido. They don't really have a sex drive anymore, right? That's males and females, right? Next one is actually you lose the ability to climax, okay? So again, your initial thought, you might be like, heck yes, I'm a sex stud. I can go for like 45 minutes to an hour, which is great until you've actually been doing something for like 45 minutes to an hour and nothing is happening, and then your partner's like, get off of me. So again, that inability to climax, it causes problems, right? And of course, that last one is you actually cause like that erectile dysfunction in males or females. Again, kind of messing with that blood supply, serotonin. They don't get arousal really anymore. So you can cause problems all 3 in 3 different populations, right? And that's the sexual dysfunction is a big reason people stop taking our meds. In reality, it's only about 30% of the population is going to have a sexual dysfunction because of an SSRI. But it's one of our biggest problems, okay? So this one, seizure disorders. Anytime I'm giving an SSRI and there's a med that's in the atypical, that's very well known for this that we'll talk about, I'm dropping that seizure threshold. So if somebody has a history of seizures, something to counsel them on and make them be aware of, And then if somebody's using alcohol on top of that, alcohol drops seizure threshold, SSRIs can drop seizure threshold. Now all of a sudden that patient's in the danger zone. So make sure you know your patient's history, okay? And then lastly, this is kind of unique to the SSRIs. This is where you need to make sure you have a good history of your patient and kind of a good family history. And very select patients who have bipolar disorder or are at risk for developing bipolar disorder, you can actually flip somebody into a manic state when you're using an SSRI. So you actually can induce mania in somebody. So something to be aware of and counsel them on. It's not as severe, but it can definitely put them in that kind of starting to skirt that hypomanic manic state that we'll talk about towards the end of the lecture. All right, so this is all the drugs. I rarely recommend memorizing every single drug, but just for your clinical practice, to make yourself good providers, this is a category where you probably want to know all the drugs that are in it. It's relatively easy to know them and what sets them apart because you guys are going to use these pretty frequently in your practice, right? You're going to prescribe for depression and anxiety very often, right? Seldomly cause cardiac arrhythmias. There's one exception, citalopram. It actually has a black box warning for causing an arrhythmia. And escitalopram, because it is that racemic mixture, it's not as known to cause it, but it's one of those risk factors, which is why we rarely go above the FDA recommended limit for these, and why they're kind of reserved more towards that second, third line, okay? So first up, citalopram, right? So major depressive disorder, off-label used for kind of that anxiety, and then there's that black box warning. So anytime something has a black box warning, it's good to know it. We don't go above 40 milligrams in dose, right? If you guys have noticed in my lectures, I rarely talk about dosing or dose ranges. This is one of those exceptions where I'm going to say like, hey, do not go above 40 milligrams at your guys' level, okay? Because that risk for QTC prolongation is so great, right? Next, you have Lexapro. Again, it's kind of that racemic mixture of the citalopram. Lower side effect profile. Kind of a great way to think about Lexapro is it's basically like a glass of water, right? It's not going to cause a whole lot of effects, but it can be good to do. So if I have a patient who's kind of like on the borderline of depression, anxiety, where they think they need a med, but maybe I don't need one of my heavy hitters, I'll usually go with Lexapro because it's great. You go 10 milligrams, 20 milligrams. That's it. Super easy to dose. You only got two options, right? Start low, bring them up to high. So next up, fluoxetine or Prozac. This is like one of the first SSRIs that came onto the market. We use it for a lot of different things, and we have a lot of good data behind Prozac. Prozac is a great drug. It's one of my favorites, right? But it has some unique characteristics, right? Indication, so it can be used for almost everything. And it's one of our only SSRIs that actually has an FDA approval for bulimia nervosa, right? So we can actually use this drug. It's been approved in a patient who has bulimia. None of the other drugs are approved for that. We kind of use them off-label, but this is one of those ones that pops up pretty frequently when we talk about test questioning PANS because it's so unique, right? And bulimia can be such a problem. It's hard, very difficult to treat, right? When you're talking about the effects, all the SSRIs can cause hyponatremia, which is essentially SIADH. But Prozac is one of the ones that's more known for it. So essentially, I give this medication, it causes a dysregulation within the body's ability to regulate its urine. And now all of a sudden you start peeing out a lot, right? So it interferes with your diuretic hormone. Not super common, very rare, but something to be aware of. It's one of those effects we don't want to miss, okay? The other kind of cool thing about Prozac is it has the longest half-life. So between the primary drug and its metabolite, when it's metabolized, you can actually get about a week's worth of effect out of a single dose of Prozac, right? And that's a benefit and a curse, because if I have a patient who is really scatterbrained, they're not good about taking their medications, they constantly miss doses, which is one of the things we talked about, right? Compliance is always an issue. The more frequently you have to take something, the compliance starts to dip, right? So this guy, if I give it to a patient who's constantly missing doses, they miss 1 or 2 days, Prozac will cover them because it's good for 8 before you start to have that dip. So it's a great drug in that respect. The flip side of that is if somebody's having a bad reaction to Prozac, So maybe it's like super sedating, or maybe kind of flipped them into that manic state. Maybe they're having those suicidal thoughts starting to increase in frequency. It takes a week for those symptoms to go away because of how long the half-life is for this drug and because of its metabolites, right? So keep that in mind. It's very neat in that respect. Decrease that risk of discontinuation syndrome. So you take these meds very consistently and they work, but when you stop suddenly, you kind of get this reverse. Anxiety starts to increase, sweating starts to increase. Maybe they kind of start to get a little bit of that anxiety respect. That's discontinuation syndrome, right? This medication, because again, it has that very long half-life, you can let somebody self-taper off of this med. It's like, hey, stop it, you're good to go, right? Whereas with our other SSRIs, when we taper off, we take them slowly over time, over a couple weeks off of the drug, depending on how high a dose they are, okay? So next, we have fluvoxamine. Fluvoxamine is kind of like the forgotten sibling of the SSRI world. It's only approved for one thing, OCD. That's it. So when you're talking about the SSRI categories, that's the only thing you really use it for, unless somebody has failed multiple things, then I'll throw that one on, right? But otherwise, that's kind of what sets this apart, kind of makes it unique, is that OCD dosing, okay? Before I go to the next slide, because Prozac is a little bit weird, any questions about the two drugs on this page at all? Cool. Good. Remember, biggest thing with this, Prozac, that decreases discontinuation syndrome, that very long half-life. Those are like the two big things to know about that, and that bulimia nervosa, right? So next up, paroxetine or Paxil. When I told you guys one of these meds we commonly dose at night, that is Paxil. Paxil is known for making people super sleepy. It's also the most likely to cause weight gain, right? So a great way to think about Prozac is think of it as a fat parrot, right? Makes you super sleepy, makes you super fat. When we do use it, we use it at night, okay? But what is unique about paroxetine is PTSD. We only actually have two medications that are FDA approved for PTSD, right? One of them being Paxil, the other one being Zoloft or sertraline. So it's important to know that when you're talking about these meds. That's why we use it. And it actually works. Like, I've had patients who've had pretty severe PTSD. They failed multiple meds, and I just tell them, like, hey, we're going to use Paxil. These are the known risk factors for it. Like, we're going to go ahead and use it. They've had a great response to Paxil, right? Also, something else that's kind of unique to know about this, it's when we're talking about pregnancy, we generally want to keep our moms on their SSRIs just because that mental health condition is usually worse for the baby than the medication is, right? With the exception of Paxil. If they're on Paxil, we try and switch them off because 1 in 25 births are associated with a ventral septal defect, right? So it's a medication that we know causes an actual birth defect. So that's what's unique also about Paxil, okay? Next, we got Zoloft, right? So again, PTSD, it actually has that FDA approval. Also, when we're talking about our elderly patients and we're talking about our pregnant patients, this is our preferred drug, right? Actually, and for kids for that matter too. It's like one of our go-to for kids. Because it's the least likely to have all of the bad side effects, okay? It can still cause them. Patient still needs to be counseled on everything that can occur, but it's the drug that's least likely to kind of cause all this stuff. It has a really good efficacy, and the dose range is super high. I usually start somebody at like 25 milligrams. You can go all the way up to 200 milligrams, so you get a broad window to kind of tailor that med to the individual and how they're responding, okay? So cytochrome P450, again, I'm not going to go in super in-depth into all of the different enzymes. What you guys just kind of need to keep in mind is cytochrome P450, it plays a big part when we're talking about mental health. And really what it is you either have some people who they have a lot of the enzyme and it acts on the med and it decreases the effectiveness because they're burning through it so quickly, right? Then you have other people who don't have a lot of enzyme and now they're not burning through that med very quickly. So now I get way more in the system than I wanted to, right? So if you have somebody who has a lot of really bad side effects and they've been on the med for a while, they might have C450 deficiency, right? Something to be aware of. Or if you have somebody, you take them up to high dose and they're getting like no response whatsoever, they might have C450 like excess of the enzyme that's in there. Okay, and there's a bunch that fall within that category that's probably beyond what you need to know at the primary care level. If you want to know more about that, like that's where you kind of go into behavioral health and into that specialty. Like I hate it, but it's something we get beat up on pretty consistently. Okay, right down there. And actually, so fun fact. Yeah, so fun fact, you can actually order genetic testing to check for cytochrome 450, and it'll actually come back and it'll tell you what enzymes they actually have and what psychiatric meds are most likely to be beneficial for that patient. So genetic testing is becoming a big tool within the psychiatric field. So, any questions about the SSRIs? Yes?
So when you say about all those drugs that are FDA approved, are we talking about those who are first-line drugs?
Yeah, so if it has an FDA approval, that means it's first line, that's one of the ones we want to use for that condition, right? Yep. Yeah, when you're talking about FDA approval, I think I've already said this, it costs a lot of money to take a drug through the FDA approval process. So when somebody, it has that indication, that means the company is paid for all of the research, the trials to do that. And then what happens is they don't want to go back because it becomes a generic, so they lose their patent for it, becomes generic on the market, and now the company has no real reason to pay all that money to take it through for another indication. And that's where we start to use things off-label. That's why Prozac is used for so many conditions off-label, because it's just like, hey, it works, we have a lot of data, this is a company hasn't paid for that. Right? Good. Any other questions about SSRI? Yes?
Are we typically, as military providers, going to be kind of initiating this and then consulting with BH after that? Like, is it always going to be a punt?
Nope.
Or a consult? Is
nope.
This mostly
so the way it kind of works, this is how it works on the civilian sector too, actually. So before you can send somebody up to behavioral health for a prescriber, usually our wait times are 1 to 2 months before you can come in and see us, right? Like there's a high need for us, and when you're talking about triaging resources, we can't send every single person to a psychiatric prescriber for med management. We want to, but you can't, right? So a lot of times what will happen is the therapist will get in, they'll see them, it could be a social worker, it could be a behavioral therapist, a psychologist, something like that. They'll evaluate, they'll diagnose, and then they'll send them over to you all and say, hey, this is what's going on with them, I need you to do med management, right? So then general practice is you want someone to be a treatment failure before they come up and see us at the psychiatric realm. Treatment failure being they've tried 2 different medications for at least 6 months and they've been taken to max dose. Okay. Yeah. Good question. Anything else? Yes.
So sir, so then would you, I guess for PTSD, would you use Zoloft first and then Paxil?
Either one. It depends on the patient. My go-to is going to usually be Zoloft or sertraline because of the side effects associated with paroxetine, right? But again, I use both. You just have to counsel that patient on the side effects, right?
Is being on any of these drugs limiting jobs?
Interesting question. How are we doing on time? That's very, okay, we're doing good. Right, so great question, right? Especially because it's very military specific. Asterisks everywhere. In general, being on one of these medications is not going to limit the jobs that you can apply for and the jobs that you can do. It's not going to affect your deployment status, right? However, if you've just been initiated on this medication, if you're treatment naive, we do place a profile because we want to see you for that follow-up, right? I need to be able to see you to make sure this med is working, right? So I need to keep you on station. You're not there to deploy. You're not going to be able to go to drill. You're not going to be able to go to selection because I need you to make sure this med's working, to make sure you're not having a worsening of your side effects, right? Then once you're stable, profile ends, like, hey man, you're good to go. It's just like any other daily med you're going to take for the rest of your time, right? Now where it can cause problems, when you're talking about these highly specialized schools like Ranger, SF, any of those, even top secret security clearances, they usually are going to do a big background check on you. You might get a psych eval, and that's where having some of these diagnoses, it can lessen your chances. You can say like, hey, like you're not going to be a good fit. Every time you've hit a high stress environment, you've had an immediately spike in all of your conditions. So for that reason, we're not going to clear you, right? And that's where it can come into play. Okay. Same thing when you're talking about. A big one for Air Force is your drone operators, your security, anybody who works in the SCIF. It can cause some problems in there because that person's entered a high-risk state. They're more likely to make impulsive decisions, so we can actually remove somebody's security clearance and kind of downgrade them temporarily while they're on these meds. And then once they're stabilized, they get everything back again, right? So it's a very temporary condition, but so no, it doesn't cause effects, but it can depending on the person in the scenario. Does that answer your question? Yes. Correct. Yeah, so anytime, so if I'm initiating a psych profile, I'm not gonna let them handle their weapon, right? Because of that black box warning, right? We don't want them, we are always about mitigating risk. So I'm gonna initiate a profile, I'm gonna say like, hey, for 90 days, they can't have their weapon, right? So if somebody who's on gate guard duty or arming status, MPs, same thing, it's, security forces, you can actually downgrade somebody and be like, hey, limit their access to weapons temporarily. And then once they're stabilized on the bed, profile start, they get everything back, right? And as with everything in the military, you just, if you like, you have to have them on deployment, you just submit an ETP, it goes up to the theater, and the theater commander will approve, theater medical will approve or disapprove that waiver, right? Good, yes?
If you deny anyone's commissioning physical for any of these drugs that you prescribe to them?
So commissioning physical, asterisks everywhere again. So in general, no. What will happen is, let's say like worst case scenario, you get a student who's going through a commissioning program, right? They have a really hard time, they get diagnosed with a condition, whether it be like anxiety, depression, we start them on that med, right? Again, once if that temporary profile is expired before they go for the physical, no issues, no problem, right? If they're on profile when they go to that physical, technically, when you're talking about admission standards, they won't meet criteria anymore. However, all we do is we submit a waiver. It goes up through command, and 9 times out of 10, they're going to approve that waiver and say, yes, they can still commission, right? It's very rare that we don't, and usually there's a lot of other stuff going on in the background to deny somebody's commission, right? So, and remember, it's getting way too military. Admission standards are very different from retention standards, right? So, we need to keep going for time's sake. If there's more military questions, I'd love to answer them. We can talk about them on the break. Otherwise, I need to keep going so I don't go over, right? All right, so next up, we have our SNRIs. So these ones came on the market a little bit later on. The big thing that's kind of different when you're talking about mechanism of action for these is now I'm blocking serotonin, but I'm also blocking norepinephrine, right? So now I'm hitting 2 different receptors, but now I'm causing an increase in both. And this is where it kind of starts to affect that epinephrine, norepinephrine, and a little bit into the dopamine, but it's not truly used to kind of blockade that dopamine or increase the amount of dopamine, right? So again, if you're looking at the side effect profile, pretty similar to the SSRIs, right? There should be one exception, which is right here. Elevated diastolic blood pressure. This is one of those ones that you absolutely need to know. I've seen this pop up, one, in clinical practice, right? Because we manage blood pressure quite often in the primary care realm. But also, test question, Panry here, like we'll give you a scenario where a patient like will lay out their vitals and will have hypertension in their vital set, right? I'm not going to tell you they have hypertension because you guys know how to assess vitals. You've had anatomy and physiology, right? It's going to be on you to catch that and be like, hey, this guy has hypertension. And I'm going to tell you what drug you want to start him on. And I'm going to list a bunch of stuff out. If people have hypertension in general, we want to try and avoid starting them on an SNRI first because it's going to cause the elevation in their diastolic blood pressure, right? Also, to go along with that, anytime you are considering starting somebody on an SNRI, we actually want to make sure we get a good set of vitals on them so we know what their baseline is. We start them on the med and then they become hypertensive. We can actually link that back to the drug. Like, okay, this is what was causing it. Let's either A, get you on a different med that's working, right? Or we can switch drug classes entirely. So again, that's when you're talking about this, that's kind of like the big one, the elevated diastolic blood pressure. Otherwise, it's very similar. So this is all your SNRIs. When you're talking about memorization, which drugs you actually 100% need to know, just for clinical practice and life in general, duloxetine is a big one, and venlafaxine, right? Like those are your 2, they're heavy hitters, we use them pretty frequently in practice. These other ones, they exist, but they're not shown to necessarily be any better than the other 2. They have less FDA indications, but otherwise side effect profiles still relatively the same, okay? Again, increase that blood pressure. Increase blood pressure. All right. So first up, desvenlafaxine. So desvenlafaxine, it's that racemic mixture of the venlafaxine, right? So essentially what happened is venlafaxine came on the market. Another drug company said, hey, I want some of that. They changed the chemical compound, and ta-da, now they have a trade name drug that they can market, right? That's really kind of where that stuff comes into. So when you're talking about your adverse effects, that's pretty the same for all those, really only used for NDD. And otherwise, not too much unique about that. It does all the same stuff that venlafaxine does, right? So next, duloxetine. Duloxetine is a great drug. It's one of my primary ones that I use that's in this category. It works well, and it has this extra benefit of diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain, right? So if I have a patient who's coming in, they happen to have depression, anxiety, whatever it happens to be, I'm looking through their record and I see, hey, they also have a lot of chronic pain that's been ongoing. They haven't responded to like physical therapy and these other treatments. This can be a drug that I'll start with because now I can kill two birds with one stone. I can improve their pain, which is making everything worse, and I can help treat their depression, right? That's a great drug to use. I think I even put it there at the bottom, right down here. Coexisting pain syndrome, right? It's a great one for that. Also, because these drugs tend to be very activating, if I have a patient who has a lot of like energy, like they just don't want to get up in the morning, they have low motivation, they don't want to do anything, they feel like they literally will tell me I don't have energy. A lot of times going with duloxetine or venlafaxine can be a great step because it kind of gives them a little pep in their step, right? Kind of get them up, get them moving, get them to go do things. Next up, levomilnicarpine and milnicarpine. These are the exact same drugs. Again, the kind of that we're seeing, make sure one of them only has the FDA approval for fibromyalgia, so I don't really use it in the psychiatric practice, right? Because it's only used for this, that's pain management's world. Even though everybody loves to punt over to psych, like that's not us, that's pain management, right? And then levomilnicarpine really only has that approval for MDD. Otherwise, nothing really makes them stand out that much, right? But I just kind of realized for distractors and stuff like that, it's easy to throw those on there and get you guys confused. So be aware of that. So venlafaxine. Venlafaxine is another great drug. Use it quite a bit. The problem with venlafaxine from a clinical perspective is the dosing. It's a pain in the butt to dose, right? So it has a very narrow half-life, and the patient misses the dose even by like an hour or 2 hours. They can start to have that withdrawal syndrome, right? Anxiety starts to creep up, they get a little bit sweaty, they get a little bit antsy. They even miss by a couple hours. So they have to be very precise with their dosing. The other problem with this one is you start off at like a weird dose. It's like 37.5. But then I have to get them as quickly as I can to like that 75 milligrams, 125. I have to get them in that realm for it to actually start working. So the dosing, it takes a little bit more care. You have to have a good relationship with that patient to really use this med effectively, right? So again, risk of discontinuation requires a slow taper. So this is one of those drugs I absolutely tell the patient, like, hey, whatever you do, if you don't like this drug, don't stop cold turkey. I need to take you off slowly over time, right? And this is where I talk, so in general, we don't target dopamine that much, right? However, with this drug, 150, primarily the serotonin receptor is the one it's blocking. The higher I take it, the more receptors it starts to hit. When I get somebody up to like 450, which in the primary care world, like, I mean, you have to be real comfortable with the drugs to take someone that high. That's where it's actually start to hit dopamine. It can actually cause a blockade in there and increase the amount of dopamine that they have, right? Something to be aware of. So again, they usually don't put too many doses on them, but higher than 450 start to affect dopamine. Less than 150, I'm really only hitting serotonin, okay? So if I want the SN portion of it, I gotta take them higher than that. All right, that's the SNRIs. We're doing good. Any questions about SNRIs? All right, cool. I got 5 minutes. We'll try and do the rest of the MAOIs, or at least talk about it. All right, so next you have your monoamine oxidase inhibitors. Again, these drugs kind of came out in the 50s with the TCAs, and for a while there, this is really all we had. These drugs are not used really in primary care, or primary care and in psychiatry at all, right? Like you have to have failed multiple drugs for us to reach into the bucket for an MAOI, right? So the drugs themselves you don't really need to, it's good to know them, but really you want to know the adverse effects when it comes to the MAOIs, because they'll always pop up in test questions because they're so unique with what they cause, right? With the exception being, if you're going to get into geriatric medicine, so Parkinson's disease, some other ones, that's actually where these drugs start to be used a lot, is in Parkinson's disease. Because actually it's been shown to increase the amount of, I think it's levodopa or dopa, something like that. I don't know, one of those two, right? You can kind of see the problem with these, when you're talking about the pharmacokinetics and mechanism of action, is this irreversibly binds, right? So, if you guys talk about aspirin at all yet? Not yet? Okay. So aspirin is one of those drugs that irreversibly binds, which means once I give it, I have to wait for that new blood cell essentially to be created for it to lose its effect, right? That can take 90 days. It's the same problem with MAOIs. They irreversibly blind that receptor, so I have to wait for the body to corrode it and get rid of it, because it's always recycling stuff, and create new ones for it to be effective. So once I give this drug to somebody, if they're gonna have a bad reaction to it, I have to manage the symptoms. There's no way I can reverse it or prevent it, right? Or sorry, there's no way I can reverse it, I can't prevent it. So that's a really big problem with these, is that irreversible binding, right? And really you need to hit greater than 60% to really start to have an effect in the depression world, which is at that point, like you're hitting a ton of the receptors. So a big problem with the MAOIs is just hypertensive crisis, right? So the moment I give this drug, because it's not just in the brain, it's throughout the entire body and causing this blockade, and then the person will go in and they'll take another medication, they're gonna take a food or something like that, and all of a sudden they go into hypertension, and that hypertension keeps going up and up and up, and now they've entered crisis to the point where now they need to go to the ER, and it can affect their life, right? That's where the biggest one we're talking about, that's where you see a lot, is hypertensive crisis. That's something you need to know about this drug class, right? And then, I don't know what it is about test writers, and this goes for like the PANS, the PANRY. For some reason, we love to ask this right here. What foods cause this hypertensive crisis? I think maybe because it's fun and unique. But essentially, if your diet is very consistent with the Middle Ages, that means you're eating a lot of tyrosine-rich foods, right? So if you're eating a lot of smoked meats, cheese, wine, beer, getting a lot of tyrine, and if they give you an MAOI, it's gonna go increase, and now all of a sudden you have hypertensive crisis, right? I don't know why we like to ask that question, but I've seen it consistently. When I was in IPAP, that was a question. I kid you not, on my pants, that was a question. And I kid you not, in the PANRY, I had this question as well when I moved my renewal cycle, right? I can tell you guys, I have never counseled a patient to not eat smoked meat and aged cheese, right? Because again, we don't really use this category. They have to fail everything. And even then, at my level now in psychiatry, if I was considering an MAOI, I would probably punt to a psychiatrist who has experience with these. That's how rarely we use this drug class, okay? So again, all of these agents can interact with MAOIs and they can precipitate a hypertensive crisis, right? You can see that this list is pretty massive. When you're thinking about testing and stuff like that, usually it's kind of like the food question, but also know some of the basic categories that can cause a hypertensive crisis, because usually we'll paint you a picture with a patient and ask you what's going on, right? So these are all of our MAOIs. That puts us right at 10 minutes, which is a great stopping point. So we'll stop here, okay? Take your 10-minute break. Oh, also, if you're one of my counselees, I know I'm like 2 weeks late, but I have you monthly counseling. So if you So if you guys want to do, like, this is just your general one, but you don't want to do it great, I have no concerns. If you want like a one-on-one, just let me know. Otherwise, that's all your message.
I live far, so I get here early. I got up, I drink coffee. Anytime I run, like, I was drink coffee, like, and I would like do a bunch of stretching. I study a little bit, and then just go over here. I'm old. I have a prep in my arm.
You're not old. You're like 25. That's not old.
I think he's okay.
You got the fastest time.
I don't trust him either, but like I feel like he's overplayed it. Underplayed it a lot. That's not like I think he's overplaying it.
Yeah. Yeah, I usually don't like. I usually just when
He
I run, I
wasn't
don't.
joking like how you
I just
said it,
run
but I don't.
whatever
I
it
think
is.
he said
And so like at the end, I don't usually like push it because I just finish how I run it, you know. And then you took off. I was like, I can't let him separate that. So I had to like pick up a little bit.
Yeah, I know you're right.
Yeah. No, if I haven't run that much, I started getting shins once I started running. It's like, the road running is like part of my shins. So like, when it's like kind of inconvenient to like go to the track and go around in circles, plus treadmill running, it's just the worst. I really like those CrossFit runners. You've seen those that are like, yeah, it's just how fast you push. Yeah, they're kind of like ergonomic for like your gait. I kind of always like those. I did a lot of PT for like beach abs, and I always like doing those during PT sessions. So like just road running is just hard. It took like 3 or 4 weeks off of my work. Oh yeah. Yeah.
I was like, I'm looking at my chain, big weapons, and on. I'm just I'll go home and shower. Then you can cap off all day.
Good for you. That's just like at like 13 miles, like I like have this like realization like so happy about this. Yeah, not like I'm not doing it under 13 because like that's like
Yeah, but like
it's hard, but it's not like the last elevated. Like it's just like I just know it's.
No, you said you were. Because even on your page, they give you a reference range.
Yeah, it's kind of like your battle elements a little bit. It's like they can be kind of fun too, like when you're kind of like moving and like moving in group. Yeah. Go down into it's pretty. I mean, the atmosphere is fun. You know,
I've had it.
rest of the night, like they're racing, they're running here, and you see like thousands of dollars worth of shoes. You know, because everybody's got like a $10 pair of fancy.
So I think you would say something
Yeah.
like, I think you just had instruction to golf have a stone block.
When I read it, they had like later days, so you know, I read it.
Because like it's not, the stone's not long. Yeah, it can't push it. So now that's getting backed up into the liver, it goes straight to the bloodstream, where it extracts that, pisses it out.
Yeah, that's really cool.
Yeah.
How does that work? Is like the red get like clear that's doing it, then like to run through.
Because B can also be chronic, but the issue is also have the chance. But C doesn't have vaccine, it's just A and B.
Now the weather is in December. It should be like mid-60s. Still, I would think, I don't know. Yeah. Probably be a little colder if you have an early start. But it'll probably be nice. Yeah. I did, my wife was one who initially was like, we're gonna do the half in Italy. I'm like, okay, let's do that. And then like a month before, I was like, I probably should go out like a little bit before we just show up. Because I always thought like, okay, I can now go and just suffer through for 13 miles, you know? And that was like, when I ran that one, I started off really hot. And then like the last half, I was just like kicking myself. Man, I probably should have done the last one I did was really cool. It was in it's called Heidelberg in Germany, and it's like it was a river town. So like I ran across the river's old college town, and to go across, and it's just mountains. You run up it, and then you run down it, and it's all trail. Like train trail was like in some of the inclines, you used to run 30 miles. Like my elevation change is like more than like any guy I'd never run. Like I never had that much elevation. Really, sounds fun. Yeah, like those jumps. I like those. That was much better. I think like training. There's one like it's kind of sad. Like you're thinking like you're gonna run places. And they just like put you outside of the city and ran right out to a park, and then like ran around a huge park, and then came back into the city to finish. Too much logistics to close off Paris streets for a race. Where good. That'd be fun. The back row, y'all, back row crew is running it. Yeah. Not this semester. Yeah, that's a good time to do it. Yeah, easy, man.
Alright, everybody. That puts us at 10 minutes, so we'll go ahead and jump right back in, right? Okay, so we kind of talked about the overall category of the MAOI. We talked about some of those unique side effects, one of them being that hypertensive crisis. Now we're kind of going to jump into the meds themselves. Another big thing to know about these drugs is that you have to have that washout period. Anytime I'm going between an MAOI and starting another drug, right? Or the reverse, going from like they failed multiple drugs, now I want to start an MAOI, they have to have a washout period. Because one of the things we'll talk about here in a couple slides is the risk of serotonin syndrome, which is a medical emergency. It starts to skirt that realm of malignant hyperthermia, that neuroleptic hyperthermia. It's that kind of same idea. It's just now we're causing it with just serotonin, right? So something to be aware of. Remember that 5-week washout for fluoxetine, and remember the reason for that is fluoxetine has a very long half-life, right? You're talking about 8 days out of that single med. Remember that. The other ones, because they have a lot shorter half-life, I can use a shorter washout period. Really only need 2 weeks for the other SSRIs, right? So it's important to know those time frames, just because they tend to pop up a little bit when you're talking about testing and in clinical practice. Knowing a washout period for a drug is good to know, okay? All right. So now we're gonna talk about the MAOIs, just kind of go over them. Again, try and focus on what makes them unique. So that might be the route that we give it, that might be the thing that we use it for. But in general, these are all going to be, in the psychiatric mindset, these are all going to be reserved for somebody who's very treatment resistant. That's where we're going to use it, okay? They're all going to carry about the same side effect profile. They all have that same risk for that hypertensive crisis, and they're the most likely drug class to cause serotonin syndrome as a whole, okay? Okay, treatment-resistant depression, TRD, that's how I'm going to use that acronym kind of throughout as well. And of course, you've got that atypical depression. We'll talk about that in the psychiatric. That's depression that is not consistent with the DSM-5. It's a pain in the butt diagnosis to make. So these are our first two, Marped and Nardil. Again, nothing really stands out about them. Good luck trying to memorize that, right? Carnate. I'm sorry, I was like the best way to describe that. So you just got to know them. There's like no good acronym. There's nothing really about them, right? So again, hypertensive crisis, timing-free diet, drug interactions, washout required. That's pretty consistent with all of these. I was a little bit hesitant to kind of include this one. It's not available in the United States market, so again, I'm not going to test you on it, but just kind of for your general awareness as you guys become clinicians, this might make it over to our marketplace. And what makes it unique is this is actually used in Europe and it's reversible. So they actually came out with a new MAOI because the Europeans are actually a little bit ahead of us when it comes to the psychiatric world with meds. And they actually have a reversible MAOI that they can use. Now I can give an agent and reverse that, right? So it's interesting. But otherwise, that's why I included that on there, right? Pleasuring, believe it or not, this is where we start to get into Parkinson's disease. This is really where this one is used. And it has a patch. So when I use the patch, I'm giving a relatively low dose, so I need a lot less diet restrictions in place with that, right? Just realize if you're trying to treat a mental health disorder, you're actually going to have to take them a higher up, so that patch isn't going to work for a psychiatric condition. That's very specific to just Parkinson's disease. They use that. I don't have to worry as much about the diet, right? So razazoline, it's the same thing. Parkinson's disease is really where these two are only used. Okay, yes?
So the two names, is that one for the patch and one for the oral?
Yes,
Okay.
correct. Yeah. So again, anytime I can come up with a new route, a different chemical compound, that means I now have a trade or a patent on it, so now I can sell it as a brand name and get more money. All right.
Sir?
Yes?
Sorry, in our last
No,
block,
no, you're good.
we call these MOIBs.
Yes.
They have no difference, right? They're just with the difference.
So technically, yes, there is a difference. You have MAOIs is like the overall categories, and then you have MAOIAs and MAOBs, right? From the psychiatric perspective, I really don't care. Just realize some of these drugs are more likely to target its receptor. So one of these drugs targets the B receptors, other these drugs target the A receptor. right? That's really how they break it down. And usually, I think first generation, don't quote me, is A's and second generation is B's. Major Hart, am I accurate with that? No, don't worry about it. No one cares about anyone else anyway. No, I'm just kidding. Yeah, did I answer your question? Good enough? Good enough to everyone working. I'm not even, actually, I got paid. So before we go into the atypicals, which is kind of like all over the place, any questions about the MAOIs? So the biggest thing to know with these, again, is that hypertensive crisis, the side effects that they cause, they irreversibly bind, right? And usually we give something else with these, and now all of a sudden it causes all sorts of problems, or the patient needs to be counseled that they need to monitor their diet and avoid all this other stuff because it can cause hypertensive crisis. And of course, the biggest thing is the washout periods, 5 weeks with Prozac, 2 weeks for everything else. Okay? Those are like the big takeaways from this category. Unless you really like to know drugs, in which case, like, I don't need to memorize it. I recommend that you memorize it. As an instructor, I say memorize it. All right, atypical antidepressants. So these are drugs that we use pretty commonly, but they don't fall neatly into the SSRI, SNRI, TCA kind of umbrella, okay? So first one, so these are all of them, right? So we'll talk about all of these. Unfortunately, nothing really links these all together. They don't share a mechanism of action. They just kind of got to know them, right? There's not even a good mnemonic I have for these, right? So if you guys come up with a good mnemonic, you'll have to let me know. So first one up,
Gotcha.
bupropion or Wellbutrin. It's a super interesting drug, right? It actually tends to affect the norepinephrine. So it really kind of hits that one a lot, especially at those higher doses. We also start to mess a little bit with the dopamine as well. So we can get some good improvement with that, again, depending on the dose that you're using. Indication, so again, major depressive disorder is really where we use this one a lot. You also have to know your patient, because your patient, if they're a smoker and you start them on Wellbutrin, it'll actually cause a really nasty taste for their cigarettes. A little bit with chewing tobacco as well. I don't know about vape and I don't know about Zen pouches. I haven't talked to my patients about that yet. So now all of a sudden you're affecting their tobacco and they don't like that, right? So if your patient's dead set on continuing their tobacco, right, probably don't use this one because it's going to cause bad taste. They're going to quit that med, right? With that being said, for our tobacco cessation classes, right, we only have really like 2 or 3 drugs that have been shown to reduce tobacco use. This is one of them that we can use, right? And we kind of get that added effect as well. So when you're using smoking cessation, it's called Zyban. Interesting enough with Wellbutrin, because it tends to be very activating, it can cause a little bit of anorexia, so somebody is just not as hungry as much when they're on this drug. They actually combined it with naltrexone, and you can use it as a weight loss drug, and it's called Contrave, right? It's one of our FDA-approved combinations for weight loss, okay? Now that doesn't, it's actually a unique formulation. If you wanted to use this for weight loss, you actually have to order the drug. It's rather expensive because it's new on the market. And essentially what they did is they just used really weird dosing, right? So they use like 78 milligrams of Wellbutrin and they use like 12.5 of naltrexone, which you can't get to with just the normal meds. And that's how they were able to market it, kind of get a trade on that, right? So if you wanted to do this like in your clinical practice and you didn't want somebody to have to pay for the name brand, you can sort of make Contrave on your own by just prescribing the 2 drugs together. That's where you have to counsel your patient, like, hey, this is not FDA approved whatsoever. You need to be aware of what's going on. But I can save you some money because maybe your insurance is not going to cover it, okay? Effects, so tachycardia, agitation, insomnia, because it tends to be very activating. And the big thing to know about bupropion is that it actually lowers your seizure threshold. So the big thing to know about this category, besides the unique mechanism of action, is it can increase somebody's risk for seizures, right? So if you have somebody who has a history of seizures and now they're also using alcohol and maybe they have depression, they were treating the depression with alcohol and they want to fix that, this is not the drug you want to use because all that stuff is stacking and you're going to give somebody a seizure, right? It's going to cause a lot of problems. So it's important to know that about Wellbutrin. You can actually use this in combo. So when we're talking about augmenting therapy, you can have somebody in SSRI and an SNRI, and maybe it's working, but you need that little extra. A lot of times we can throw on Wellbutrin. It tends to work pretty well for that, right? Another thing, so if you're dealing with somebody who has depression, and maybe all those other SSRIs have caused sexual dysfunction, and they're like, man, I will not give a drug if you're going to affect my sex life. This is a great drug for that person because it is not associated with any sort of sexual dysfunction, right? And that's where I'll tell that person, like, hey, that's awesome. I have a great drug for you. Let's go ahead and use it as Wellbutrin. Just be aware of those other risk factors in that drug. In that population, where sexual dysfunction is a big concern, this is a great drug for that, right? Interestingly enough, fun little factoid for y'all, Wellbutrin can actually be a drug of abuse. This is really big in the prison population. When I was on my addiction medicine rotation, I was working with nurse practitioner Ms. Parmo, she's awesome. She used to work in the prisons up in Colorado. And essentially, because there's a really high drug use problem within that population, they can't get their heroin, they can't get their meth anymore, they can't get these drugs. So what they do is they have depression, they don't like all the other drugs because of the side effects, they get prescribed Wellbutrin, and if you crush up Wellbutrin and you snort it, you inject it, you smoke it, it bypasses the liver, and then essentially it converts into amphetamine, right? So you have to take it orally and to go through the liver to convert it out of that state. So if you want to use it as a drug of abuse, take a different route, you avoid the liver, you're done, now you're taking basically meth, right? Super interesting. And your patients, and believe it or not, I actually had a patient, he had essentially abused every single substance known to man, and we were talking with him, he's like, oh yeah, Wellbutrin, I've had that. Yeah, I snorted it, it gets you high. I'm like, oh, cool. So yeah, people do actually abuse this drug. It's one of our drugs of abuse, right? In a very specific population. So if you have somebody who has a substance use disorder history, you might want to avoid using this drug, right? Because an addict, they will find a way to abuse. It's what they do. And there's nothing like that's why you're trying to fix them, right? So again, that seizure threshold risk, that's something to know about. Again, not crazy high. Patients need to be aware of that, right? So that's Wellbutrin. Next up, we have trazodone. So trazodone is an interesting drug. It was actually originally marketed as an antidepressant, but it really didn't show any real benefit. Made patients super drowsy and sleepy, so it kind of fell by the wayside. Didn't really get a whole lot of traction and use. But one of the things we found was patients have a lot of sleep disorders when they have mental health conditions. They just can't sleep or stay asleep. And we can actually add on trazodone. We're really hitting that H1 histamine release, so it causes them to be super drowsy. So if you have a patient who has difficulty initiating sleep, this can be a great drug, right? You can just add that on and be like, hey, take your Zoloft in the morning, take your trazodone at night. And the added benefit is you're also targeting that serotonin a little bit. So you're kind of doing that augmentation therapy and helping your sleep, and you kind of get some good effect with trazodone doing that as well, right? If you go up to 200 milligrams, now you're outside of that sleep-wake cycle, and now it's actually being used as an antidepressant when you go up that high. On the primary care side, most of you guys aren't going to do that. But if you get into psychiatry, this is a drug that's very useful. Because what I can do is I give them 150 at night to put them to sleep. And then during the day, if they have a lot of anxiety, I'll have them take like another 25 in the morning and 25 in the afternoon. And now I can kind of control that anxiety throughout the day. So we can get a lot of use out of it. Again, just a little fun factoid for y'all, right? Good. So interesting. I don't know. In theory, any of our antidepressants can cause priapism. But for some reason, trazodone has really been linked to priapism. I've given out a lot of trazodone. I've never had somebody have this condition, right? Interestingly enough, I was taking care of a patient on the cancer floor, and he had priapism, but it was actually from Wellbutrin. So no, sorry, not Wellbutrin. It was from Zoloft. So the one case I've actually seen of it was caused by a completely different drug. But without fail, test question-wise, PANS, PANRE, they're always going to have a patient and be like, what do you need to counsel them on? And they're going to be like, they want to start trazodone. Without fail, it's always like, well, you need to counsel them on priapism, right? So a great way to remember what trazodone is known for, trazodone, trazobone, right? That's how I kind of remember it in my mind, okay? So next up, you have nifazanone. Again, this is just another version of this, and it was actually removed from market because it was really known to cause this hepatotoxicity, right? So we don't really use it anymore. You can still find it in a generic formulation. I've never actually seen it prescribed, but it's still out there. Just realize, like, it's not true black box warning because it was removed, but hepatotoxicity is a bad one with this one, okay? So next up, mirtazapine, or Rimron. This one is a great drug, and it's kind of unique. So it has that mixed mechanism of action, and it's kind of starting to hit the serotonin, but it goes to 2 different receptors. And I'm not going to expect you guys to remember these receptors just because they're so unique. But essentially, we're targeting very different receptors, and now we're starting to get that effect. And kind of getting that release of that norepinephrine. And then what's unique about it is the side effect profile. So a lot of our antidepressants, they can cause that weight gain, but paroxetine is one that's definitely known to cause it. And this is our other one that's really known to cause weight gain. So essentially, you're increasing somebody's appetite when they're on this drug, so they start eating more, and then you're interfering with your leptin and your, the other one, I forget that. You're starting to interfere with your hormones that affect digestion, and now all of a sudden people start putting on a lot of weight. They tend to balloon up pretty quickly, put them on mirtazapine, right? If that's going to occur, it happens within about the first month of starting this med. If you're 2 or 3 months down the road and the person hasn't put on any weight, it's usually a great sign that they're going to respond well to this medication, but something to be aware of, right? The other thing that's kind of unique about this drug is at low dose, so you're talking at the starter doses, it actually causes a lot of fatigue, sedation, it really hits that H1 histamine, and at high doses, you really start to affect those receptors, the serotonin, you kind of get that norepinephrine, that increase on that side. So if I have somebody who has a lot of sleep issues, and they're already on like a Zoloft or Prozac or duloxetine, they're still having problems with their sleep, I'll actually add this one on and use it at low dose to kind of help as a sleep aid, right? So low doses targets more the H1. As you go up in dose, it starts to target the other receptors a lot better, okay? Also, we were talking about that agranulocytosis, right? This is not one of the known like risk factors. This is not like a side effect or an adverse effect, but there actually are some case reports of people actually getting agranulocytosis from this drug, right? It's not really testable, but something to just clinically be aware of when you start this med. If somebody starts to get really sick for no reason, something you might want to check, right? Again, we've already kind of talked about pretty common to use this in combination. If you have a patient who's worried about their weight, this is one that you want to avoid because it is known to cause that weight gain, okay? So S-ketamine. Everybody loves ketamine for some reason, right? Ketamine is a super interesting drug. Do you guys remember, does anybody know Matthew Perry, the guy who played Friends? What did he die from?
Hot tub.
Hot tub, but what was he on? Yeah, he was on ketamine. So essentially what had happened is like he was getting prescribed ketamine from a doc who just didn't care, they were in it for the money. He overdosed on ketamine, became sedated, and basically just died in his hot tub, right? Because of ketamine. It's a drug of abuse. So ketamine itself is not approved for any sort of FDA indication for like depression, anxiety, suicidality, right? There's actually, again, that racemic mixture is called S-ketamine or Spirivo, and the reason this one is approved, they actually went to the market, they did all the trials, and it's a nasal, and it's been shown to reduce suicidality and treatment-resistant depression. So that's the version that's actually approved by FDA, right? Is Spirivo. Sorry, Spravato, S-ketamine, I mixed the two together. But you can actually use regular ketamine for treatment-resistant depression and to reduce acute suicidality. You can use it in that realm. It's just not FDA approved in that formulation, right? And essentially the idea behind this, it's not super well understood why it does this, but we think we're starting to hit that NMDA receptor, which NMDA, your GABA, that starts to affect your dopamine, that starts to go into that realm of abuse, right? Anytime we're starting to mess with that pathway, we run that risk of abuse. And it kind of increases neurogenesis, so now our neurons are creating new branches, and we think that helps somebody kind of formulate these ideas, gets them out of depression, stuff like that. So very unique mechanism of action. It's not super well understood. We kind of know what's going on with that, right? That suicide effect, just so you all are aware, it's really only for about 7 days, and then it starts to wear off, and that suicidality is coming back. So really, that buys you just enough time for to take somebody out of an emergency situation and get them in and established with care and get them onto something better. But it's very effective for that acute suicidality. It's a really good drug for that, right? Just on a, yes, I'm going to hop on a soapbox for just a second. All right, so have any of you guys seen like the pop-ups recently with all like the ketamine clinics and stuff like that are starting to occur a lot? Are you guys seeing all those ads now that starting to pop up? Again, this is why. The problem with that is because ketamine has been predominantly used by the ER and by anesthesia. Those are the docs, because they're familiar with the drug, they're setting up ketamine clinics, right? So they're not necessarily associated with a therapist, with psychiatry, they're not associated with the behavioral health world. This is a doc who wants to make some extra money, and he goes, oh yeah, you're depressed, perfect, here's some ketamine for you. And now you're coming in every week, every 2 weeks, every month for your ketamine infusion to make yourself feel better, right? So just be aware of what your patients are doing on their own, because if they're not doing the right thing, it's not actually making them better. You just substituted one drug for another drug, and now you're a drug dealer, essentially, right? The biggest problem with this drug when you're talking about that adverse effects is that disassociation, right? So you're actually disconnecting somebody from their body. That's kind of like the disassociation effect, which again can be super helpful when somebody's in pain, not necessarily helpful when you're trying to treat somebody's depression or anxiety, okay? And then this drug, if you're using it, they are supposed to be on their RIMS, which is reported up, and you're checking for those adverse effects, and technically the provider is supposed to be registered with that system, okay? Next up, zuranolone or brexanolone. So this drug, I just wanted to include this in there to talk about postpartum depression. It doesn't really fit within this antidepressant category, but postpartum depression is a pretty significant issue. We talk about 30% of our moms go on to develop postpartum depression, right? Either in the middle of pregnancy or after. And it can cause a lot of adverse effects when it comes to that mother-baby bonding, right? And the worst case scenarios, you can actually start to get neglect of the infant. The mom just doesn't have that connection to take care of them, right? It's a significant medical concern. We need to make sure we're screening for this and addressing it. We can start them on SSRIs, SNRIs, which are great. We can get them with therapy. But also, we have these new drugs that came onto the market, and what's great about them is that we only give them for a very short time frame. So you're talking about, with this newest one right here, you're giving it once daily for 14 days. And that's the treatment window, right? So now your compliance is not something they have to take every single day for months at a time. They come in, they see you, they take their med. You only do that for 14 days. And the remission rate is about as consistent as it is with our antidepressant medication. We're talking about 50 to 60%, depending on the person, depending on the study that was done. So it's actually pretty effective. And what's unique about it is it's basically you're messing around with their steroids, right? So the body naturally produces steroids. We think inflammation plays a part in postpartum depression. So if I reduce that inflammation, now all of a sudden they start to do a lot better, and it gives a chance for the hormones to kind of re-regulate themselves after they've given birth or in the middle of pregnancy, right? This one used to be and the reason they kind of discontinued it was a pain in the butt to use. They had to come in once a day for an infusion. So that was always a problem because they have to be in clinic for an hour, have it slowly infused, they have to come back consistently, right? They just came out with this newer formulation. That's actually the oral medication. So now we're having a lot better effect with that, right? But just be aware, depending on how up to date the PANS and the PANRE are, you might see either one of these. It could be labeled either way. So just kind of keep both of those in mind. They kind of do the exact same thing. I'm not going to test you on a route, but I might test you on like why we use it, how long we use it, how many days they need to come in. That's something because it's the same whether it's IV or oral, right? But just realize you might see either one. Okay. Good. Any questions on this slide? So next up, vilazodone. So what's happening is we're in psychiatry, we're much better at detecting what's going on with the brain, and we're starting to realize there's a whole host of receptors that do different things, and we're starting to design these drugs that go after those specific receptors. So now instead of taking a wrecking ball and then taking a sledgehammer, now we're getting much more precise, and we're going at it with like an ice pick or a scalpel to try and target these receptors specifically, right? And that's where you get the lazodone and the next drug, Trintellix, which is the brand name, right? The downside to these drugs is they actually haven't been shown to be any more effective than the older SSRIs. And they're only available in the brand name formulation, so they're very, very expensive. I was trying to get on an update to get you guys the actual pricing for these next two. Wasn't able to get it to work for me, but you're talking like $300 or $400 for a 30-day prescription, right? Which for your average person, if they don't have good insurance, that's a heck of a lot of money for a med that's not any better than the other ones, right? Big thing with this one, besides the mechanism of action, is you have to take this with food. So it increases that absorption and makes the medication much more effective. So when you're counseling a patient to put them on this, when I say like, hey, take this with your morning meal, make sure you're having a good like bagel or some eggs or something like that to make it more effective, right? Next up, vortioxetine or Trintellix, same thing. Designer drug, we're starting to hit a lot of these other receptors to see if we get some improvement. Not shown to necessarily be better than any of the other antidepressants, except in one very specific population. Patients who have a lot of cognitive dysfunction, this drug has been shown is actually approved to improve that, right? So this is people who maybe like, they can't think clearly, their mind is super clouded, maybe they're very kind of retarded in their thought processing, everything's like very slow. This drug has been shown to have some great effect in that population, but just realize it's also a very expensive drug to use that. And outside of that very niche population, not necessarily shown to be any better. Yes?
So with these designer drugs, you said the efficacy is about the same as SSRIs. Do they have less adverse effects? Is there any benefit we see right now?
No, and again, the side effect profile is pretty much the same. The efficacy is about the same. But we're trying to branch out and hit other receptors. So the way I kind of approach it is if I have a patient who's failed like multiple SSRIs, and then I've tried SNRIs and they failed that, and then I'll say, hey, how's your insurance? How are you doing? Like, let's talk about some other stuff. Let's go with one of these and see if they work. Because now I'm targeting different receptors and see if I can get a different effect, right? Psychiatry is a super interesting subspecialty because with genetic testing, the more we're learning with neuroimaging, we're actually starting to find out a lot more about these pathways. And it's going to try, I think, in the next 10 to 15 years, it's going to turn into a much more individualized kind of subspecialty where I look at the individual, I get my testing, find out what's going to work best for them, and then I start them on that med. Right? But we're not there yet. It's still way too expensive, way too niche for us to go that route. Right? A good question. Anything else? Okay. So vortioxetine, again, outside of that cognitive dysfunction, not really shown to be any better, rather expensive, kind of very similar side effect profile. This one does not have to be taken with that food to increase the bioavailability. Right. So kind of overall, the drug classes as a whole, adverse interactions. So TCAs, increase those levels of antipsychotics, calcium channel blockers. So TCAs affect, again, remember that wrecking ball comes in and hits everything, starts to interact with a lot of our other drugs, and that's where we kind of start to cause those problems. Increased levels of your carbamazepine, so this one will kind of come into play when you're talking about neuro, seizure disorders, different things like that can start to affect those meds, okay? SSRIs, so again, that cytochrome P450 inhibition causes them something to know. Like if your drug interfects with that, you need to counsel them about their diet and kind of talk about that. We'll leave it at that for right now. Fluoxetine, the greatest effect, and certainly has the least effect when you're talking about cytochrome P450, right? When you're talking about inhibition or activation of those. SSRIs are also, I think you guys just kind of went over, did you guys go over benzos yet? I think you guys did, right? So just realize if I'm giving somebody a benzo maybe for their anxiety and I also have them on an SSRI, I might have to drop the dose on that benzodiazepine because it's meant to mess with that and interfere and increase the amount that's available. I can make somebody super sedated with those drug interactions. The other kind of ones to know about, I know warfarin's kind of falling by the wayside. It's not one of the ones we use that much, but it's still out there. SSRIs, they actually increase bleeding time, so they make it harder for somebody to kind of clot up and stuff like that. So if somebody's on warfarin and they're also on an SSRI, you're going to increase that even more. We may have to discontinue the SSRI if they're getting prepped for like a surgery or something like that. So to be aware of these SSRIs, they do increase that bleeding time. Should not be concurrent with triptans. that's by your book. I will tell you guys that I do commonly have people on SSRIs, they have migraine, they're gonna be on triptans. That's where you need to counsel that person. And really what it is those triptans are used as abortive meds, so they're only using it very situationally. And if that's the case, I'll tell the person, be like, hey, did you take your med this morning? That's fine, let's just hold off, we'll take it again tomorrow. So you're not causing that risk for interference with seizures and some other disorders and stuff like that. That's by your book, it's something to know, but we still commonly use the two together quite often. And of course, MAOIs, I think I've talked about this multiple times. I don't think I need to go over it again. Really, the big thing to know about MAOIs is the side effect profiles, what bad things it can cause. All right, serotonin syndrome. This is going to be very similar to malignant neuroleptic syndrome or malignant hyperthermia. A lot of those side effects you're going to see the same. Again, I don't think I need to go crazy in depth with that. Big thing being that kind of like to have that agitation, restlessness, confusion. Confusion will be a big one. And then that temperature, that core temp is really what you want to monitor because you don't want somebody going into like 104, 103 degree Fahrenheit fever while they're on these meds. That's where we start to have those bad side effects, okay? Big thing to know, right? So treatment windows. So we always want to do that supportive care first. That's why we kind of make sure that they're cool, stop the offending agent, and we actually have an antidote, right? So cyproheptadine, that's something to know. Anytime you have an antidote to something, you always want to know that. So if you have somebody who's going into serotonin syndrome, their fever is super high, they're not responding to supportive care, that's actually where you're going to initiate cyproheptadine. So for you guys who want to be emergency medicine PAs, that's something you're going to encounter. It's something to be aware of and you have to know. Even primary care, it's good to know that. And testing-wise, anytime you have an antidote, it's good to know that as well, okay? Something important, the reason I put a star on this, so all of these drugs have that potential to cause serotonin syndrome, and usually what's going to cause it is I start stacking drugs on top of each other. So I'll have them on like an SSRI, then they have their amitriptyline for their migraine headache, right? Then they're put on something for fibromyalgia, by pain management. All of a sudden I'm stacking, they all interfere, and they can cause serotonin syndrome. But the biggest culprit is going to be those MAOIs. Those are the ones that are most likely to cause serotonin syndrome, right? So also kind of keep that in mind when you're talking about things you need to know. Classically, it'll be a test question. I won't say MAOI, but I might say like sledgeling. And then they also have depression. And then it's like, hey, what do they have? Serotonin syndrome. What do you do about it? Cyproheptadine. Okay, make sense? All right, any questions about serotonin syndrome? Again, I don't want to go too crazy with it because it's very similar to the other one conditions you've heard about. But it is important to know because it can kill someone. Good, okay. So, treatment considerations. I know somebody was asking me about like how often you want to see somebody back. So remember, it's going to take about 2 to 4 weeks to tell if this med is going to work. And they're going to have side effects to the med, right? The most common one being those GI symptoms, so nausea, vomiting, upset stomach. That's very common in the first 2 weeks. And that's something you can tell your patient about. It's like, hey, you're going to have a lot of this stuff. That actually means the drug is working. So because you have those side effects, I know it's hitting your receptors. It's going to wear off in about 2 to 4 weeks. And then I can check back and see how they're actually responding to that med. If you see them back in a week, they're going to tell you I'm having horrible side effects. But yeah, that's to be expected. Okay, so 2 to 4 weeks. I like to use a 4 to 6 week window, but this is a pretty good marker as well. Okay. Then once I have them stable on a medication, which can take up to 6 weeks, right, to get to an effective dose to see if it's going to work for them, I want to continue that person on the medication for generally 1 year. Right, that's like my cutoff. If I want to put you on Prozac, even if you're doing really well, I want you to stay on it for that 1 year mark, and then we can go ahead and come off of it, right? So if you say 9 months plus the time it took me to get them to an effective dose, that's how you kind of get to that 1 year, right? Because it's not from when you start, it's from when they're stable and you're no longer making dose adjustments, okay? And then kind of, I just wanted to put this last one in there just to kind of give you guys a reality check. So yes, we're kind of painting this rosy picture that these meds are going to do amazing things and everybody's going to be fixed. That's not necessarily the case. So of our patients who have major depression, 50%, so of that 60, 50% are actually having a reduction in their depression, right? A reduction being greater than 50% of their reported symptoms, so it's person reported. And then the downside to that is, of that 50%, only 30% actually go into a sustained remission. You're talking like multiple years down the road, right? So a lot of these patients, they may not respond to that med, and if they do respond, they might need to continue on with this med lifelong to keep control of those symptoms, right? Or you might need to have that conversation with them, be like, hey, I think we've reached therapeutic level, we've reached treatment plateau, we can't go anywhere else. Are these symptoms tolerable to you? Can you deal with the low energy, with the low mood, and kind of move on with your life, right? That's where you need to have that open, honest conversation with your patient and tell them the stats, right? If you guys want a really good article to read and you're very interested, it's the STAR-D trial. I highly recommend that you guys read that. It's kind of one of our foundational articles when you're talking about psychiatry medications and how effective they actually are. All right, so therapeutic augmentation. Biggest thing to know when we're talking about therapeutic, when we're starting to augment, is they have to fail at least 2 different medications from a different class. Big asterisks to that because testing is different from actual clinical practice. But for you all, fail 2 agents, that where we still look at augmenting, right? And that's where I can start to see what's going to work best. And essentially, it's throw a dart at the wall, take one, and see what happens, right? There are some side effects to all of these drugs. They all have their pros and cons, but one's not been shown to be better than the other. So in pregnancy, this is where you need to have that open, honest conversation with the mom and be like, hey, when you come off of these meds, you get severe major depressive, you stop taking care of yourself, you stop eating, you're not going to your appointments, right? I can keep you on the med, which has been working for you, but there are these known side effects, right? So when you're talking about the spontaneous abortion, 12% when you're on an antidepressant, right? Without an antidepressant, 8%. So you're talking about a 4% increase for spontaneous abortion. Something for that patient to be aware of. They need to be counseled on this stuff, right? Another thing to kind of think about is all these SSRIs, they do cross the placenta, so they are affecting that neurodevelopment in the kid. Another thing you can have is like, hey, let's continue on until you get close to birth and let's stop the medication in your 3rd trimester. That's another kind of compromise you can make with the mother because maybe they don't want to continue on with that med. That's another way you can keep them going because you know that the situation is going to be worse for them, right? This is very contentious, right? If you guys haven't seen it in the news and stuff like that, make sure my arrow's hitting right there. We don't have a known actual 100% like, yes, this causes autism, right? But we know everything we do affects the baby. This is something you need to talk about with the mom. There's no clear link, we can't guarantee it, but there's that risk, and they need to be aware of that, right? In general, we want to continue a medication with the exception being, paroxetine, right? Paroxetine is the one med we actually know causes a heart defect. We do want to switch them off of that onto, preferably, if you don't know any better, Zoloft. Zoloft is a preferred agent in moms and elderly, right? Boom. So, you get everything with Paxil. MAOIs, we definitely don't want to use. St. John's wort, I didn't go into it. It's an herbal supplement that a lot of people use for depression. St. John's wort causes a lot of problems. I do not recommend my patients to use that, and if they are taking it, I do my best to get them to stop because it causes a lot of problems. Clinically, to make you guys look good clinicians, if you guys need help doing pregnancy counseling, which as primary care, you guys will definitely do this, this app is a great resource. I have this on my phone. I use it anytime I'm doing any sort of like family life planning, right? What you do is you plug in the medication and it'll bring up all of the recommendations for that med and it'll tell you if it's A, B, C, what the known side effects are, what the studies say. I also have that conversation. I don't remember this stuff off of my head. I'll have that conversation with the mom as we're going through the meds that she's on right now and what we want to do about with pregnancy, right? So phase 2-wise, this is a good app. I do recommend actually downloading it, right? I don't think I have this in your guys' slide deck. I was sitting in my office thinking about it, and I was like, that's a good one to know, okay? Good. We'll go into mood stabilizers. I think you guys have covered quite a few of these in the anticonvulsant lecture, but we'll kind of double tap them. Any questions about the antidepressants? Going once? Going twice? Okay. Mood stabilizers. So mood stabilizers, we really only use them for one thing, and that's bipolar disorder, because it helps stabilize them out of that manic phase. It helps with that depressive phase when we're talking about bipolar disorder, right? We can use them off-label. for major depressive disorder. At the primary care level, you guys probably aren't going to initiate this, but you might get them back once they're stable. And you just have to kind of monitor the levels, make sure that they're working, okay? So real quick, bipolar disorder, just realize it consists of two parts. You have mania. So the acronym for this that you guys need to remember is DIGFAST, right? Won't go too much into that right now. And then you also have the depressive phase, which is all like major depressive disorder. So they go from manic, super bad, to super depressed, and you get these big swings, right? Usually you're talking about 1 to 2 episodes per year if they're not being effectively treated, right? Bipolar disorder is a medical emergency. It's something that needs to be addressed time now, especially when you're talking about type 1. Type 1 bipolar disorder is going to end in one of 3 ways. It's going to end with that patient being in prison, it's going to end with that patient being inpatient, or it's going to end in the death of the patient. That's how severe mania is, right? Not something you mess around with. Hypomania, we'll talk about that in psychiatry. Just realize it's the same stuff, just not as severe. Okay? So anytime we're talking about treatment for bipolar disorder, the first thing we need to address is usually that mania. That's where we need to get one of these on board, right? And then we worry about the depression afterwards, and that's where we can kind of start to worry about this stuff. Those antipsychotics, they're kind of rearing their ugly head again. We only use those in the manic state to get them stabilized, and then we'll peel those drugs off because of the high side effect profile, right? Mood stabilizers, that's something that patient is going to take for the rest of their life, right? Because we have to have them stable. They come off that bed, they're going to go back into a manic state, which is bad. Antidepressants, remember we had talked about all of those antidepressants that carry that risk of converting somebody into a bipolar state. So generally we discontinue those. And then if we do want to bring them back on, that's where that psychiatrist needs to sit down and have a talk with that patient. Generally, big asterisks don't do that, okay? So these are all of our mood stabilizers. So again, you guys are probably already familiar with these when you talked about your anticonvulsant lecture, right? Interestingly enough, not all of our anticonvulsants can be used for mood stabilizers. There's only really like 3 of them that have actually been shown to be beneficial. And we don't really know why. Like, we don't have a good understanding. We have an idea, right? We think we're hitting these secondary messengers over here, right? And we think that that's where it's getting the biggest effect, but we don't actually know. And that's why we can't use all of them. The biggest one is going to be that lithium. That's one that was very commonly used. It's kind of fallen out of favor because of the side effect profile and how difficult it is to dose. That was one of the first ones, right? All right. So, carbamazepine. This is your first one. We started off in that acute manic state. It's a pretty good drug. It's pretty easy to dose. Some of the side effect profile, again, kind of keep that in mind. It's a very interesting side effect profile. Very similar to lamotrigine. Again, lamotrigine, we don't actually use it that much in the manic state. We use it more in that maintenance. We want to get somebody under control first, and then if they're having some severe side effects, like the lithium, the valproic acid, the carbamazepine, then we switch them over to lamotrigine. But it's not really the best for that manic state, right? Also, Stevens-Johnson syndrome, that can occur with any of the anticonvulsants, but it's really been associated a lot with that lamotrigine, right? Anytime we're doing these for monitoring-wise, this is your labs you're ordering, so a complete blood count, liver function panel, complete metabolic panel, urinary analysis. We're doing those kind of every 3 months while somebody's starting up on the drug, and then once they're stable, you can convert over to 1 year, except for the carbamazepine, which you're checking that every 6, right? So again, this is one of those drugs, you're gonna see them, they don't ever stop taking it. They're gonna continue on with these mood stabilizers for the rest of their life, right? And then that weight, because a lot of them may cause weight gain. Now with the menstrual cycle, why do you guys think you wanna ask about that and worry about that? It can, but also pregnancy, right? You want to make sure that that patient has not become pregnant, because these drugs definitely cause some problems, right? With one of them being known to be very teratogenic, and if the mom is on that, like we definitely switch them off because it causes neural tube defects, right? So you're always worrying about that pregnancy. It's one of the biggest things, right? Good. So first up, valproic acid or Depakote, you guys have already kind of talked about this, so I'm not going to hit this too much on the head. The biggest issue with this is that black box warning, and right here, the teratogenicity. So if I have a mom who's of childbearing age, I usually don't go with valproic acid, right? Just because the risks is there. Maybe if they're on an IUD or an Explanon, I'll talk with them. But people can go and get those things removed, and they don't tell anybody, right? And now it's all cause problems. Interestingly, this teratogenicity, it's not well proven. We don't exactly have a clear understanding. But in males, it actually causes some demyelination of the sperm. It affects the DNA, and now that baby, if the dad was on valproic acid, they can actually have some developmental disorders later on in life, right? So it's actually valproic acid starting to fall out of favor for a mood stabilizer because of those developmental effects. Because again, you're going to be young when you get bipolar disorder. A lot of these people can go on to have kids and families and be successful once it's under control. But valproic acid can cause a lot of those problems, right? So pyramid, the only reason I included this is because technically it is, it has some effect, right? It's one of those anticonvulsants. We do not use dopyramate for mood stabilizer, right? With that being said, it has a whole bunch of other uses that we can use it for. It's never really first line for anything. It's always second line. But don't get confused if I give you if you get a bipolar patient and it's like, what do you want to start them on? Don't pick dopyramate, right? That's why I kind of included this one on there. I think they're talking, I want to talk about that. Yes, I'm good with that. Okay. So lithium, yes. So we'll talk about that in psychiatry. So the basic gist of it is, normal mania, you're having like 1 to 2 episodes per year. And somebody who's a rapid cycler for mania, they're actually having 4 or more episodes in 1 single year, right? So they're constantly going into that manic state. They're much more difficult to treat. The meds don't work as well. They need to be usually more aggressive with the treatment, okay? All right, so lithium. Lithium is a very important drug to know, right? Because it's one of our only few drugs that actually has been shown to reduce suicidality over the long term for our patients, right? So if you remember the other ones, ketamine or S-ketamine has been shown to reduce acute suicidality, and then carbamazepine clozapine, that antipsychotic is the other one that's been shown to actually reduce suicidality. Outside of that, really lithium, that's it, right? And lithium is interesting because it's not actually a drug. If you guys remember your periodic table, it's an element, right? So it's naturally occurring. So if you have somebody who's like super resistant to drugs, you can kind of be like, hey, well, how about a naturally occurring element? And you can use lithium. And the history behind lithium is also super interesting. It was actually found in Australia, and essentially it was naturally occurring in the water supply. They stopped it, and the suicide rates went up in that town where lithium was naturally occurring, right? Biggest thing to know about lithium is monitoring levels, right? I haven't really told you guys about blood plasma concentration and how we monitor that. This is one that you absolutely have to know. You need to know the appropriate drug plasma concentration, because if you go outside of that realm, either if you're too low, the drug's not effective, and if you're too high, you cause lithium toxicity, right? And it's something that anytime you're dealing with a lithium patient and there's a change, a new sickness, a new med, you want to check that blood plasma concentration. You have to know it, right? Because everything affects your lithium, right? Dehydration, fever, new meds, diets, it all affects it. So you have to do good monitoring when you're messing around with lithium, right? And I got you your workup panel right there, right? Adverse effects, so you will 100% get a question about lithium. You need to know lithium forwards and backwards, right? And usually the biggest worry is that lithium toxicity, because it's going to affect the kidneys. And the very presenting symptom that you're going to see a lot is they start off with a very fine tremor that they've never actually had. So anytime your patient says they're having kind of like a little bit of a shake or their hands moving a little bit more, that should trigger in you like, hey, I need to check their lithium level. Right? I need to make sure they're not going into toxic state. Okay? But yeah, lithium, 100%, you need to know it forward and back, right? Another one, thyroid. So you need to always check that thyroid because you can burn somebody out when they're on their lithium, okay? Usually that's going to be when you're first starting it. Within that first 6 months, you always want to worry about that thyroid. And then you got hypothyroidism, right? These are all the drugs that can affect lithium. I don't necessarily think you need to memorize this chart. This is more just to tell you guys, like, hey, everything affects lithium. If you get a lithium patient, there's a change from their baseline, you need to worry about it and check those levels. Treatment considerations, again, very similar. We're going to continue that lithium for 9 to 12 months. In actuality, you're going to continue on for their lifespan, just depending on which med works best for them. Carbamazepine, that's kind of my go-to. I tend to like that one more than the other ones. They all have bad side effects. In my mind, that's the least bad option, right? But you want to tailor your treatment plan to the patient and what's going on with them, okay? Good. And tremors associated with lithium. You can actually fix that with beta blockers, so as it side off. All right. Any questions about our mood seal? I know I burned through it quick, but you guys have already covered like half of them in your anticonvulsant lecture. The biggest one is lithium, right? Depakote, bad for baby. Any questions? All right. That's all I got for you guys. You guys need a movie recommendation? Robin Williams, definitely recommend. Everybody who's a provider should definitely watch Patch Adams. 100%. If you want to be in medicine, you need to watch that. If you guys are super interested in psychiatry, The Awakening, super interesting movie to watch. It actually is based on real life events. Right? Cool. That's all I got for y'all.